Hello, I am Dr. Dezetta Burnett. I'm a licensed clinical social worker, and I've been teaching a DSM-5 class since 2020 to MSW and psychology students. And over those years, I kept seeing the same patterns, right? Students could identify major depressive disorder, they knew the criteria, but the moment those patterns changed or elevated mood appeared, everything fell apart. And that's when I discovered that if I'm having this issue, other faculty members are too. And faculty don't just want you to know what MDD is, not even your clinical supervision site. They want you to explain why it's not bipolar one or bipolar two. So today I'm going to walk you through the complete mood disorder spectrum, right? We're going to talk about major depressive disorder, persistent depressive disorder, bipolar one, bipolar two, and cyclothymic. By the end, you should know exactly how to differentiate these and justify your clinical reason. Clinical reasoning, let's start. Let me share my screen. It's large enough for you to see. Um, so we're gonna start, let's start with major depressive disorder. The way I teach my students to remember the 9 symptoms is with a mnemonic called SIG E CAPS, right? SIG E CAPS. And so we're gonna start with the S, which is sleep changes, insomnia, or hypersomnia. The I is interest loss, which is anhedonia. The G is guilt or worthlessness. The E, energy loss or fatigue. C, concentration problems. A, appetite or weight changes. P, psychomotor changes, which could be agitation or retardation. And S, suicidal thoughts. The key to this is you need 5 or more of these at least 2 weeks, and one must be either depressed mood or anhedonia, right? This is your baseline. Again, 5 or more for 2 weeks, one must be depressed mood or anhedonia, okay? So let's take a look at, we're gonna move to mania now. The mnemonic for mania is dig fast. And dig fast is D, distractibility, I, indiscretion or risky behavior. The G is grandiosity, flight of ideas is for F. A is activity increase, which is goal orient directed or agitation. S is the sleep need is decreased. T, talkative, but this pressured speech, right? With this, you only need 3 or more for at least 1 week. If the mood is only irritable, you need 4, right? So you need 3 or more for at least 1 week. If the mood is only irritable, you need 4. We'll talk about this more. I'm just giving you the mnemonics. Okay. Another thing I want you to keep in mind is that it's 1 week or more any duration if hospitalized. So let's say someone gets hospitalized for elevated mood, that automatically meets the duration, even if it's only been 3 days. And I'm looking at my notes and I'm messing them all up, so please forgive me. So, critical, I want you to think about this. It's 1 week or more, any duration if hospitalized. If someone gets hospitalized for elevated mood, that automatically meets the criteria, even if it's only been 3 days. Okay. For mania. So now let's talk about bipolar one versus bipolar two. Bipolar one goes high, bipolar two goes low, right? You go high with full mania for bipolar one, which is one manic episode is all you need. You can have depression, it might happen, but it might not happen. That doesn't matter with bipolar one. What matters is if you have one manic episode ever, bipolar one forever. One manic episode ever, bipolar one forever. For bipolar two, you go low, meaning depression is the main problem. That is like the overall symptom. So this person has hypomania, which is less severe elevated mood, plus major depression. I want you to, and we'll go through this again. But I want you to remember that because with bipolar one, the mania is 1 week or more, severe impairment. Often the person is hospitalized. There are psychotic features that can occur. Bipolar two, hypomania, it's 4 days. but there's no severe impairment and it's less likely hospitalized, right? The person normally doesn't have any psychotic features, no hospitalization. When you hear that, it automatically take you to bipolar 2. When you hear depression, right? One manic episode, you can start looking at if there's any mania, it's automatically bipolar 1. If it's any depression, we're looking at depression, it's bipolar 2. Because remember, major depression can occur. Um, it is usually the functional impairment of bipolar 2. With bipolar 1, it's depression may or may not occur, but the mania is required. You have to have mania for bipolar 1. Okay. So let's take a look at the comparison tables here. Um, Again, also what I want to mention is if psychotic features occur during what looks like hypomania, that's not hypomania, it's mania. You see some psychotic features that it looks like hypomania, you've got to move that over to mania. That diagnosis becomes bipolar 1 because psychotic features, mania equals bipolar 1 always, right? Mania equals bipolar 1 always, just like one manic episode ever, bipolar 1 forever, okay? So now let's look at the chart. I want to take you to the chart. I'm a visual person. And what happened was when I was learning, I needed to see these things and how they all line up. And so this is just the way I'm a visual learner. And this is how I really operate. I want to show you the 5 disorders side by side, and you'll see how everything fits together. We'll talk about the core pattern, which is what defines each disorder, right? The duration, this is critical when we talk about duration. Um, we'll talk about manic versus hypomanic presence. This is the key differentiator of the symptoms. And then psychotic features, when they change, the diagnosis is what we're going to look at. But I want to point out these key distinctions. Major depressive disorder, 2 weeks, right? And duration. Persistent depressive disorder, 2 years, 1 year in youth. Okay. And we're talking about mania, right? Full mania is required for bipolar 1. Hypomania is required for bipolar 2. And we're talking about cyclothymic. It's this cycle, right? They're fluctuating symptoms. They never fully meet the criteria of the other disorders. Okay. So when we're looking at major depressive disorder, remember 5 symptoms for 2 weeks. One of those symptoms must be depressed mood or anhedonia. And then we're talking about persistent depressive disorder. This person is depressed most of the time, and they have 2 or more symptoms, right? Bipolar 1, at least one manic episode equals bipolar forever. Bipolar 2 is one hypomanic plus one major depressive episode. I think people get confused with that. The way you remember bipolar 1 versus 2, bipolar 1, any mania, it automatically becomes bipolar 1. Any hypomania, the person isn't hospitalized, there's no psychotic features. Take a really good look at bipolar 2. And cyclothymic is this cycle that continues to happen. Okay. Now let's take a look at, so we talked about all that. That's one thing, but then you want to see it in practice. Like, okay, so that the theory is one thing. Now let's see how this plays out in an actual case. So we know what the criteria is, but what does that look like in an actual case? I'm going to walk you through a few vignettes and show you my process for reasoning. Let's start with this one. It's a 45-year-old man. That reports 2 years of feeling down most days. Low energy, poor concentration, overeating is already showing the answer. I'm sorry. Overeating. Um, he denies suicidal ideation. He says he can't remember the last time he felt normal. He has no history of elevated mood or increased energy. When I'm reading this, I'm hearing depression. It's the 2 years that has me like, wait a second, there's something else going on. I don't see a cycle though, because if we go back up here, he meets the criteria for depression. He meets the criteria for some depressed mood, right? And you only need 2 symptoms. I'm looking at those symptoms: down most days, low energy, poor concentration, overeating. He has those 2 symptoms, but he denies any suicidal ideation. So I'm not automatically, there's no mania. Bipolar 1 is out the window. There's no history of elevated mood or increased energy. I'm still like, no, I don't know. But I could look at bipolar too, but I don't see any hypomanic episode. Um, so what I do see, I mean, I see some depression, but I see like a more persistent depression, right? Something that at 2 years is letting me know this isn't a short period of time. And so that's why I would look at persistent depressive disorder, right? Because there's chronic depression and he has these additional symptoms. It's less acute than major depressive disorder, but it's persistent. And I don't see any manic, like I said, or hypomanic history. So I ruled out bipolar. Now let's take a look at this 30-year-old woman. She presents after a week of decreased sleep. So she feels rested after she's had 3 hours. But there's this rapid speech. She's starting three new business ventures. She's spending $20,000 on clothes. She was hospitalized 6 months ago, and she had a 3-week period of depressed mood. So there are a few things that I want us to go back to. She has a decreased need for sleep. The rapid speech. We know that you can have that in major depressive disorder. You can have a decreased need for sleep. Um, Rapid speech. You could have this pressure to keep talking. She started through three new business ventures and spending $20,000. There's this risky behavior. She was hospitalized. That's what's got me looking at, okay, so what's going on? Because remember, one manic episode equals bipolar one forever. So I'm thinking that. And then 6 months ago, she had a 3-week period of depressed mood. So let's go back and look at bipolar one, right? We see some mania. There's some elevated expansive, right? We don't see irritability, so she doesn't have to meet the four symptoms. It seems to be appearing for a week, more than a week, right? She's been hospitalized. So the hospitalization already pulled out the bipolar two. I wouldn't cyclothymic because she meets the criteria. I wouldn't even consider that. It's been less than 2 years. So persistent depressive disorder. I could look at here, right? But I there's no mania in major depressive disorder. So the fact that there's some mania here based on her behavior, right? I would be looking at bipolar one. And let's take a look. Bipolar one, right? She meets the criteria. Remember that mnemonic, big, fast symptoms causing severe impairment and hospitalization, distractibility, increased need, increase indiscretion, that risky behavior we talked about, the grandiosity, the sleep need decreased, and then that flight of ideas and that talkative pressured speech. And now she has this like goal-oriented behavior. So that is bipolar one. Let's do one more and we're gonna wrap up. One more. This 28-year-old. We're gonna take a look at this 28-year-old. Hold on one second. Do. I have a lot of screens up. And now my things are getting mixed up. Hold on. Okay, so now we're gonna look at where we did bipolar one. Okay, so let's look at this 28-year-old that reports periods of feeling on top of the world, right? Um, this on top of the world is lasting 5 to 6 days with decreased sleep, increased productivity, more talkative than usual. The friends notice, but he continues working. He also has a major depressive episode. Okay. So feeling on top of the world, that there's some feeling on top of the world lasting 5 days, the decreased sleep, increased productivity, more talkative than usual. The friends notice he continues working. So we see, let's go back up here so you can take a look. You see some hypomania, right? Um, we see some hypomania. I wish I had this side by side. But we see that decreased sleep, increased productivity, talkative, um, more talkative than usual. So we see some depression symptoms, but it's the hypomania that is in there. Like we see the hypomanic episode. And so when we're looking at that, I'm thinking bipolar two, right? Bipolar two, because hypomania is 4 days or more. They're saying 5 or 6 days they feel on top of the world. And then there's this major depressive episode, which is bipolar two. There's no hospitalization and no psychotic features in bipolar two, right? So let's give some quick rules on exams. When we're looking at grief, grief fluctuates, depression permeates, grief has wave, depression is persistent. That's the way you can kind of like remember that. Um, so that's down here. Major depressive disorder versus persistent depressive disorder. A major depressive disorder is episodic, it's more severe. Persistent depressive disorder is chronic and lower grade, right? So 2 weeks for major depressive disorder, persistent depressive, 2 weeks or more. For persistent depressive disorder is 2 years or more. We're talking about mania, it's 1 week. Hypomania is 4 days. And so that's why in the last case, we saw that timeline 5 to 6 days. That was that hypomania. And remembering that one goes high, bipolar one goes high, bipolar two goes low. Psychotic features during hypomania actually means bipolar one. So if you see any psychotic features, you automatically should be looking at bipolar one. So what you saw on the mnemonics comparison tables, the vignette, there's practice questions here, right? Here are the practice questions. So what is the minimal duration of a manic episode? We just talked about that. 1 week or any duration if hospitalization is required. You see these. So we have the mnemonics, the questions, the vignettes. This is one module out of 150 clinical comparison libraries, right? And so when you click through the other disorders, let me take you there so you can just have a look. Sorry, it's super big. I have every disorder, right? So there's psychotic disorder, the personality disorder, mood disorders, which we just went through, feeding and eating disorders, anxiety disorders, trauma and stress related disorders, disruptive and impulsive control disorders, neurodevelopmental disorders, and substance use. Um, these are all the categories that you can look at. And for each category, let me go back. We did that one already. Let's go to psych. There are the overview, the symptoms, and then there's a table, right? So you have the same structured format for all the disorders, for all the anxiety disorders, the trauma disorders, the psychotic disorders, the personality disorders, every major differential across the DSM. And for this, I created this because I kept seeing students ask me questions. I'd host study groups, and I thought it was doing a disadvantage to some of the students. And it was unfair because other students didn't have access to that. And you get all that, let's say you want to do it for 30 days because you have an exam for $19 and there's no subscription. So let's say you're preparing for your comprehensive exams, um, you're preparing for practicum documentation, you get instant access immediately when you click this button, right? And so if you're a program director, you get team access. But I just wanted to tune in and share this information because I think it's important. So I want to thank you for watching and good luck on your exams.